here. There's two problems. One is the scope's coming out at a slight angle, and the second problem is it's falling off the bed. So to stop that happening, we move the scope back to where we were. We're watching the screen all the time. We ask the patient to move their left leg over the scope like that, and to optimize control of the scope, we will get the patient to straighten the leg out, and then we've got free movement of the hand. The hand's not restricted by the leg, and we can control the scope nicely like that.
So I just noticed as you were doing that, you can let go of the shaft of the instrument when you're doing that.
Yeah.
Yeah. And I think people, as you rightly pointed out, they worry about losing control of the instrument.
Yeah.
But actually, as we've discussed in other videos, if the patient's in the right position, the scope remains relatively stable because you're using gravity to your advantage. So rolling the patient does allow you to let go of the scope,
yes,
doesn't it? Yes.
Yes. I mean, there are the odd occasions where it's very unstable or very unstable.
A lot of time I have to, so if I'm doing a GA list, a lot of time I have them on the left. And to be honest, John, I'll be completely honest with you, a lot of time I don't move them off the left if they're anesthetized because of the difficulties of moving in a fully anesthetized patient. But when you have the experience of how to do it and you know when it will help, and that's the critical thing, right? That you know in what situation it's going to help you. It's either going to help you for a non-progression reason, not so common, I have to say, in anesthetic endoscopy, much more common that you have a polyp, it's in a difficult position, you want the stalk to elongate, you want better access. In that situation, it's critical, but the most important thing is following the basic rules that we're presenting today so that you know when it's going to help you and when to do it so that it's going to improve your access.
So I just brought this slide up, David, because I think if you could only have the patient in one position, it would probably be supine. It probably minimizes your loops. We don't do them in GA, but even in supine, you recognize that in this area, the sigmoid colon, you can have the situation where your loop just gets bigger and bigger and bigger, and you end up running out of scope. So you end up with a big loop like this, and you get to here and you're out of scope because you keep pushing in. And normally for people who are under heavy sedation or under general anesthetic, their pain receptors are obviously dampened. That's the whole reason for doing it, or that's one of the reasons for doing it. And they will not necessarily be feeling this stretch. And we have also have concerns that the propofol list can lead to trauma and injury and damage the patient. Do you want to?
Well, so the only thing I'd like to sort of add here is that I don't have much experience of propofol except the places we've visited, and what I've seen is that using propofol is not a black and white option. In Scandinavia, in Sweden particularly, they were using propofol but using as a sedation agent rather than an anesthetic agent, and I would urge the sort of propofol users to maybe rethink their practice, particularly on extubation. Do you really need that patient completely unconscious during extubation or when you're doing the therapy? Would it be unreasonable to stop the propofol when you get to the cecum? The effect of the propofol works off very quickly. So you've got a patient who's perhaps sedated on the way back and not fully anesthetized. So perhaps we could maybe introduce these things in the discussion later on.
So I'm not. It's clear from the poll that, and we know this, people are reluctant to roll the patients. We see here during intubation, 86% of people on the course day only roll the patient once. In fairness, you could say, well, so do I, but I do mine underwater, and I wonder how many of that 86% are using water intubation. But we find one of the biggest things that we have on our courses, or one of the things that most people take away, is that the optimal patient position gives you huge advantages during intubation in terms of getting the scope around. And as David's just alluded to, it's absolutely critical for therapy. And it is a paradox, but actually taking a little bit of time to move the patient increases the efficiency by which you do the procedure. So rather than failing to get around the same corner 2, 3, 4 times, which is both time consuming and potentially uncomfortable for the patient, it is much more efficient and effective to simply put the patient in a different position, which optimizes your ability to get around that particular problem.